Hello, and welcome to Discovering True Health, your weekly deep dive into health and wellness. Thank you so much for joining us. Before we get started with today's show, please hit the subscribe button. It helps us out a lot, and you'll stay up to date on all our upcoming shows. You can also check out additional information on our website, Instagram, and Facebook. All those links are below. So as mentioned on previous shows, research shows that heart disease is the leading cause of death in the US, with cancer coming in at number 2, and the numbers are steadily rising. Now, research also shows that 90% of the nearly 18 million heart disease cases worldwide could be prevented by people adopting a healthier diet, doing regular exercise, and not smoking. So today on Discovering True Health, we are going to learn more about the consequences of the lack of preventative healthcare here in the US, as well as lifestyle changes and testing that we can do to ensure our own health and longevity. We'll also be learning about a newer therapy called peptides that we can use as a method of improving our overall health, wellness, and quality of life. So my guest today is James O'Hare, a family nurse practitioner with a passion for evidence-based individualized medicine. And he utilizes an integrative approach to empower his patients to feel better and live a longer, healthier life. So thank you so much for joining us today.
Absolutely. I'm very excited to be here. Thanks for having me on, Christy.
Now, as I mentioned at the top of the show, heart disease is the number one cause of death in the United States, and in most cases is largely preventable. And you are primarily working on the cardiology unit where you witnessed firsthand the lack of preventive medicine in our medical system here in the US. So from your experience, what are the consequences of the lack of preventative health care? And what was kind of the catalyst to spark your passion around preventative medicine?
Yeah, so you made a great point at the beginning talking about just how many of these things are really preventable. So something between 80 and 90%, depending on the studies that you're looking at, cases of heart disease. And primarily we're talking about atherosclerosis. So plaque building up in the arteries, and that's something that precedes something like a heart attack or a stroke. So seeing those sorts of things come in, whether that was open heart surgery that somebody was having, or having a heart attack and then having to do the rehab afterwards, or a stroke and the rehab and kind of relearning things afterwards. And then realizing in that process that many times these things are preventable, it was the catalyst for me to kind of go back, further my education, because I wanted to do everything I could personally to prevent these, and then also be able to share that with other people and help other people in their health journey, and getting started with that sooner rather than later, because it really is kind of these heroic procedures and efforts that we have in hospitals now, as opposed to the focus up front on preventing these things. So eventually you sort of, if you see people that keep washing down the stream, instead of diving in and saving them, you work your way upstream to see why these people keep washing down the stream.
Right. Yes. And that's so key right now, is really figuring that portion of it out. Because like you said, we have these, great medical procedures that we can do, but these cases are exponentially rising as well. So there's something going on, in the younger years, and before we get to the point where we're in an emergency situation that we need to start addressing and start really thinking seriously about. Can you share with us some of your personal experiences about what you learned when taking care of patients after heart attacks and strokes?
Yeah. So a lot of times it's that, people are not expecting to be in these situations. So you see those people in a very, vulnerable place. It's an emotionally charged situation. And it's really important to, be there, be able to explain things, listening to the patient, all those things to help support them through that acute journey. But then it's really that recovery after the surgery. Take an open heart surgery, what we would call a CABG for short, coronary artery bypass grafting, where you have one of these vessels that is blocked off, and they take a vein out of your leg, and then they, take and splice that into your aorta, and then supply blood again to that distal portion of the artery. So that essentially you just build a bridge around that blockage. And that does restore blood flow. It's pretty fascinating when you think about it. But when patients wake up from these surgeries, a lot of times they have tons of chest tubes. They're in an ICU. They've got drips everywhere. And we're getting these patients up and moving, and they're in a lot of pain. So it's not something that you would want to go through especially knowing that it could be optional, right? If you are doing the right things early in life, that was really the catalyst for me, and not wanting to see people have to, suffer through these things. And I am very grateful that these procedures and technologies exist, but my interest is more so in, primary prevention versus, okay, somebody's had a heart attack, so now how do we prevent them from having another one? Because if we can prevent that first one, then that's even better.
Absolutely. And yeah, you talk about that. And so my father had gone through heart surgery, and and I went through that whole aftermath with him, and it is so difficult, the aftermath of it, and all the drugs they're on, and just the rehabilitation after. It's really, really hard to come back from that. So yeah, it's definitely something we want to think more about, the prevention of, and not go through. And as mentioned before, on one of my previous shows, my guest spoke on diseases like heart disease and how they start when we're young. They don't just, suddenly appear in our bodies, and our lifestyle and diet in our younger years have a big impact on our health in our older years. And obviously, the younger we can catch these issues through testing, the better chances we have to change our diet and lifestyle to, mitigate major diseases and procedures like this. So what should people be testing for, and types of diet, lifestyle things we should be doing in their 20s and 30s, or, earlier years, to prevent issues in their later years?
Yeah. And the atherosclerosis, the beginning stages of that, where someone has just these fatty streaks in the arteries that, they're silent. You don't feel that. You don't feel, most of the time, blood pressure going up, cholesterol going up, body weight can sneak up on people. But it actually goes back even earlier than that. Now, if we look back at, I think, the autopsies that they were doing during the Vietnam era, some of those very young soldiers were even having these fatty streaks. And we now know, even in infants whose mothers had something called FH, or familial hypercholesterolemia, that they can develop these fatty streaks by the time that they're born. This is a rather uncommon scenario, but that just shows you how early something like this can start. So there are a lot of advocates for screening even earlier than, your 20s, looking at, okay, is somebody genetically prone to these things in pediatrics, right? So that we know, oh, they're going to be at a higher risk. So we need to very carefully monitor this situation. If somebody has FH, they could be having a heart attack, 30s, 40s, instead of where you typically see those things happening around, 60s or so. And age is going to be the biggest risk factor there, but I think it carries a unfair weight right now if you look at the 10-year risk models, because you can have someone who's 20 with everything wrong, and then you're plugging in looking at, for the next 10 years, they're very low risk. But some of those things we look at, like I mentioned, the lipids, and ApoB has sort of emerged as a better marker than the LDL cholesterol. They're using that a lot in some of the European countries, and it's a little bit of a fight over here to try and get insurance to reimburse for something like that. But there's other factors, blood pressure. That's something people can check at home. You can get a blood pressure cuff, $20 or $30, and check it once or twice a week and make sure that that's not consistently running high. And then a lot of times it has to do with hydration, electrolyte status, processed foods, those sorts of things, inactivity, that are driving the blood pressure. And it can be easier to unwind that sooner rather than later. Other genetic things like lipoprotein little a. This is one that is being talked about more now. Probably about 10 years ago, there was a celebrity trainer on The Biggest Loser called Bob Harper. I believe that was his name. He had a heart attack at age 51. Great shape. You wouldn't think he had any risk factors, but he had a very high level of this genetically driven small subtype of cholesterol and that's believed to play a big role in his early heart attack. So there's a lot of things out there, and we have all the tests, and it's just as simple as a blood test and a visit with your primary care provider or specialist who's looking at this through the lens of not just the next 10 years, but for your lifetime.
Right. And as you mentioned, if this is, let's say it's something that is caught earlier through a test, can we unwind that and mitigate that if we find that out, let's say in our mid-20s? Is that something once figured out, if we have some sort of issue there through diet and lifestyle, can we kind of unwind that and get to a place where we're not going to end up having a procedure at some point, or a better chance?
In most cases, the answer is yes. You can drastically reduce your risk. Even if somebody has, all of the highest risk factors, if they're doing intensive lifestyle and exercise is going to be, foundational to any of this, then you can cut the risk by about 50%. So it's not like just because you have bad genetics, it doesn't matter because you're going to get it. You can make a drastic difference, and your lifestyle is going to be very powerful there. And there are good therapeutics that are being developed, medications that have less side effects than the older medications. With regard to the lipoprotein(a), there's some trials going on with a small interfering RNA therapy that should actually silence this particular set of gene expression to where it's as if you didn't have this. So that's going on out of the Cleveland Heart Lab. So probably some time away from mainstream right now. And I assume when that comes out, people will be tested for this much more regularly. But first, they have to look at the outcome data and make sure, hey, we lowered this, but is it actually preventing heart attacks? Is it doing what we want it to?
Right. Thank you for that information. And you mentioned babies can sometimes show, through the pregnancy and develop this. Is there anything particularly you've seen from research and studies that mothers that are pregnant can do to mitigate this development in their child? Or is this kind of like a new area where we don't know much about yet?
Yeah, so this is a fairly new area. The phenomenon is called fetal atherosclerosis that I was talking about. And it has to do a bit with epigenetic expression. So we talk with patients a lot about this in my practice with, everyone wants to set up their children with the highest odds of success. So if you take, the first 90 days prior to becoming pregnant, focus on being very healthy, right? So you're getting that aerobic exercise in, you're doing resistance training, you're getting your inflammatory markers down, you're getting lots of polyphenols, flavonoids, fiber in your diet. Those things are going to induce some positive epigenetic changes. And whether it's the epigenetics themselves that are heritable, or whether it's just creating a more favorable environment in utero, that is going to drive in part your children's health outcomes. So we know that if you have, a mother who's metabolically healthy versus a mother who has, let's say type 2 diabetes, on average, the offspring of the healthy mother is going to have better metabolic health. So there is some degree of heritability there. And it goes back to, your lifestyle that you're living before pregnancy and during pregnancy is going to, and help in part, help set up your children for good metabolic health.
Right. It's like the traditional Chinese medicine phrase of prepare the palace, they say.
Yeah, I love that.
Make sure you have, like they talk about the inflammation and, epigenetics is so great because we do have a lot more control than we think we do. We're not just kind of stuck with these things as much as we thought we were, a few years ago. Let's get into peptide therapies. I'm really excited to have this conversation because this is something newer and I feel like a lot of people don't know about. I've more recently heard about it, and I have a friend who is using peptide therapies to help an issue she's having with gut health, and it's helped her out a lot. So can you first explain to us what peptides are?
Yeah, so very simply, peptides are just a chain of amino acids. And we produce peptides endogenously, things like amylin from the pancreas. And then there's a GLP-1 that we produce endogenously. And when people talk about peptides, they're usually talking about them in a sense of like regenerative medicine. So these sort of, research peptides that may or may not necessarily be FDA approved at this time. A new one that's kind of on the market and people are talking about, semaglutide is technically a peptide. It's a peptide chain that acts as an agonist at our endogenous GLP-1 receptors. So it's a peptide, but when people are talking about peptides, sometimes other compounds like, pentosan polysulfate or androgen receptor modulators kind of get lumped into that category because they're also in the stages of kind of research. So things like BPC 157, that's a peptide that was initially derived from different compounds in the gastric juices of humans, and found to have some of these regenerative capacities. And then there are growth hormone releasing peptides and growth hormone releasing hormones that have also become more popular.
Right. So they are a naturally occurring thing in our bodies. And is this like we're remaking them, or is this something that's kind of natural? Then I'm just part of it.
It has a natural target. So you have receptors that these peptides will plug into, because you produce something that is similar. So they take these sort of peptides that we produce and they tweak them a little bit. For example, semaglutide and liraglutide are about 90% identical to our natural GLP-1. So, and sometimes they can be quite similar, but they're a little bit different because we're trying to get slightly different effects out of them. Maybe it's a longer duration of action or a more potent release of growth hormone, something like that.
Understood. And what are some of the different ways that peptides can help? What are some of the benefits? You've mentioned these growth hormones, and there's certain ones that help us kind of with recovery. And also, are there any risks or side effects?
Yeah, so yes to both, risks and side effects. In terms of the growth hormone peptides, for example, these can be useful in an acute setting, especially around an injury or if somebody is going for a surgery, and for the right patient, because they can have some side effects, but they can speed recovery and speed tissue healing, that sort of thing. But it's not something that on average I'm having people, stay on year round, because there is some risk of insulin resistance there, potential cancer risk. And it depends on how high you're pushing both growth hormone levels and then also sort of the surrogate marker that we look for in blood work of that, which is IGF-1. And there's even different proteins that will bind your IGF-1. So you can see how much of that is free and active as a really good measure of, how much anabolic potential that growth hormone is stimulating. So some people do have either hypopituitarism, where they don't produce growth hormone among other hormones, or they have an adult onset of growth hormone deficiency, where you'll see some frailty and connective tissue issues, sleep difficulties. And when you use either synthetic growth hormone or a peptide that stimulates a release of your own growth hormone, you can see those things improve. And we have data that shows sleep architecture and efficiency improves, the rate of protein synthesis and connective tissue improves. So you do see these functional improvements in tissue, but it's not necessarily what I would consider to be anti-aging, because it may slightly speed aging as a whole, because there's always a trade-off between longevity and vitality.
Right. That's a good point. And is there a menu to these peptides, per se, like a selection of, these, if we want, let's say we're losing our hair, or our hair's going gray, are there peptides for that? Or, how broad of a spectrum of different types of things can they help with?
So there's a lot of things that have a lot of promise out there. Mm-hmm. For example, you'll hear about GHK copper in a lot of regenerative processes, and that's been used, to my knowledge, for like non-healing ulcers and perhaps in burn patients as a topical, and it does drastically improve that wound healing. The data as far as reversing hair loss there with the GHK, it's sometimes promoted for that, but the data is not particularly strong. With the BPC, for example, that tends to be more related to either musculoskeletal conditions or to healing of the digestive tract. So with the BPC, if I have someone who has an acute injury, let's say that they strain something or they tear a ligament, they're getting a meniscus repair done. That's where I would see that having potentially some value, because it has a couple of mechanisms of action that we know from the preclinical research may carry over. It's not been completely elucidated in humans yet. On the contrary, the trials to heal things like ulcerative colitis or inflammatory bowel disease, gut inflammation, those things do appear to be somewhat effective and then have a relatively good safety profile in humans with the BPC 157. The one sort of theoretical risk there has to do with it promoting angiogenesis, which is the growth of new blood vessels. And this is important because that's something that if you do in fact have atypical cells, tumors, cancers, they are very blood flow hungry, and they do things to promote angiogenesis to themselves. So when I see someone who comes to me and they say, oh yeah, I've been taking this every day for the last 3 years, it makes me a little bit nervous. And I think it's better used in a specific targeted manner. So in the animal models, if you give BPC 157 to a mouse and they sever its Achilles tendon, it's going to regrow and reattach with very good strength in about 14 days. Now, we don't have those trials in humans because it's obviously unethical. But I have seen anecdotally, some people seem to do really well. Somebody's had a shoulder that's bothered them for a long time, and then they're, pain-free within a month. They just a short course of that. Then I've seen some people where it doesn't seem to pan out, and that maybe more with like back pain. I would think it would be less, specific, or I've just seen less success there because that's a little bit more complicated of a system, and it has to do with a lot of times muscle tension or muscles that are too weak also.
Right. And that's a great point to make, because I've heard that as well with an issue of taking, let's say, testosterone, where it helps everything grow and people that want to grow their muscle. But let's say you do have a tumor or cancer, it's going to help that grow too. So it has that, trade-off. That's good to have somebody that's very aware of how all those little things work. And you talk about studies. To date, have there been extensive studies and research done on peptides, or how much is out there so far?
Yeah, so most of them have some degree of human research. A lot of times it's just maybe a phase 1 trial where they're looking at the tolerability and safety of an acute dose, and then they don't necessarily make it past that in development because there's significant cost to bring a drug to market. Some peptides like sermorelin, for example, that is a growth hormone releasing hormone that is actually FDA approved. It's no longer produced by any large pharmaceutical companies, but compounding pharmacies do produce this still. So it's something that's been, it's gone through all of the processes that a drug goes through to be FDA approved. Tesamorelin is another one of those. That one is approved for a unique problem of fat accumulation called lipodystrophy in patients with HIV and muscle wasting and that sort of thing. So sometimes these ones that were used for like growth hormone deficiency in children are repurposed and then used as usually it's a cheaper alternative to synthetic growth hormone for people who are diagnosed with adult onset growth hormone deficiency. With the BPC, the musculoskeletal data is a little bit more shaky in humans than the studies where they've given people these capsules or injections and seen the improvements in gut healing. They have done injections intra-articularly into the knee, which you don't necessarily have to do because it is a systemic therapy. But that's how this one particular study was done. And they saw an improvement in function and pain level afterwards, but it didn't have a placebo arm. And we know that the placebo effect can confound a lot of things, but a short course seems to have a reasonable risk-benefit ratio, especially if somebody is younger and lower risk for a cancer, for example.
Got it. And you mentioned they're injected. So are all peptides injections when they're administered? And as well, can you kind of cover, you touched on this previously, but how often have you seen with working with your patients or from other data, would we need to get a peptide treatment for sustaining a desired outcome? And also, it seems they aren't that widely known about yet, kind of mainstream. So where would one go to get these types of treatments? Are there only particular, professionals in the health field that do them currently?
Yeah. So as far as where people can get these things safely, how they can use them in a supervised manner, it would be with the care of a healthcare professional. There's a number of websites that sell these as research chemicals, which is legal if they're used for research purposes, but it's kind of a gray area, and people will buy these things, inject them. And there have been some case reports of immunogenicity where people are making antibodies and getting some inflammation because certain things like LPS are not filtered out properly when they're manufactured. So you want to be working with some sort of medical oversight, physician, nurse practitioner, physician assistant. There's a number of different professionals that can prescribe these things, and then working with a reputable compound pharmacy. And they compound these in various forms. The injectable is going to be more bang for your buck in terms of absorption, but they also have, capsules that they make. In the case of the BPC 157, it seems to be gastrically stable. So you will still get some of the benefit, but it would tend to be a higher microgram dose. And then they do have, they'll make these troches that will dissolve buccally. So these are things that people will, put under the tongue, be sublingual, or put in the cheek, which would be buccally. And in theory, it should cross over into the bloodstream just the same. But in my experience, that the doses required are going to be much higher, and you're not going to quite recapture that effect because this wasn't how the medications were either developed or tested. And it's just not quite as efficient of a method compared to a subcutaneous injection where the bioavailability is much better.
Understood. So the injection is the best route. And as far as the length of time, you said you shouldn't be doing this for multiple years because of possible counter effects. Maybe, what's kind of the standard, or is there a standard length of time to kind of, I guess it would depend on what you're trying to achieve as well.
Yeah. So it depends on the situation. If I have someone with an injury that they're trying to rehab, or they're having a surgery, maybe a 12 to 16-week course of augmenting their growth factors with something like a growth hormone releasing hormone and a growth hormone releasing peptide combination makes a lot of sense, because you do get a bit of a synergistic response between those two. It causes your pituitary to produce more growth hormone than doubling the dose of either one would. With the BPC, that one tends to be very quick. So you either are going to feel it start working or not. So I don't see a lot of value in pushing that one out for several months. Usually something like 30 to 60 days would be enough to see if that's going to have the desired outcome. Now, if we're talking about for cartilage maintenance, there's a drug out there that's already approved called pentosan polysulfate. It's used for bladder issues in practice now, but they do have injectable forms of this, and actually some human data where they have at least a 12-month durable effect on improving the cartilage tissue in your knees. So they've given people these medications, and they've done serial imaging out to at least 12 months, and they see that there's actually a functional improvement and that's durable. So that's something that is interesting, and you could see someone using something like that maybe once a year, once every 2 years. If I have someone who's using a lot of their joints, a lot of wear and tear, someone who does marathon running or jujitsu, something like that, they're going to be putting more wear and tear on the joints, and it makes sense to push back against that a little bit. It's just not a particularly well-known medication, and again, it's produced in compounding pharmacies in the injectable form. But it is produced also as a capsule for bladder issues, FDA approved.
Fascinating. Now, for those that want to contact you and learn more about your work or to work with you, how can we do so? And can you also share with us what types of programs you have available, and if you have any other great resources around health and wellness and longevity that we can all check out?
Absolutely. So I'm on Instagram at James O'Hara NP. That's OHARA. And then the clinic that I'm a partner of is GilletteHealth.com. We are based out of Kansas City, but we also have telemedicine available. And we work in individualized medicine and concierge medicine protocols. So if you want to find out more information about that, you can come to our website, and we really focus on building out a long-term health plan for anyone that wants to sign up for us. That's kind of what we feel is, the best value and the best investment people can make in their overall health. So, as far as resources, really what's good is people who are staying on top of the research and then knowing how to kind of dissect that, right? So what weight do we assign to a new study that comes out? And it depends on if it's in humans versus in a preclinical model like a mouse, or if it's just what we call in vitro. So if it's in a petri dish in the lab. And it's kind of a sliding scale because that's where a lot of research starts, is in a petri dish, and then moves to preclinical, and then it moves to human trials. And if all goes well, then we have a new therapy that is improving human health is always the goal. So kind of knowing what is clinically relevant and what is statistically relevant is a skill that I think a lot of people, and a lot of people that I talk with, my patients, have gotten pretty good at. Like, yeah, I saw this study, but after talking to you, now I know that it was just done in cells, so we've still got to wait for this to be repeated and then move up the chain. So there's a lot of good people who are kind of debunking or discussing the good and the bad of studies out on social media now. So if you find someone who is absolutely sure of their opinion, or someone who is absolutely skeptical of everything, those are probably red flags. And you want to find someone in the middle who takes a balanced approach and can talk about both the pros and the cons.
Such great advice. And I love how you explained, the way to approach studies, because that's so important to understand. So it can get so confusing when you're not, you're the average person, you're not a healthcare professional, and really understanding what to look out for in these studies. So you're saying we should the heavier weighted studies would be the human trials. If they're just, in cells in a petri dish or with animals, we should kind of still be a bit skeptical about that particular drug.
Yeah, that drug or supplement. Exactly. So the studies that are done in humans, in ideally large numbers of humans and repeated in trials, are the ones that are very solid. The ones that are done in a mouse model, just an example is like antioxidants, like vitamin C will eliminate heart disease in a mouse model, but that does not cross over to humans. So you can give people all the vitamin C in the world, and that's not going to completely prevent heart disease. So there are some specific differences there. And definitely the weight would go more to large trials, human trials. But it's interesting to keep your finger on the pulse of the other data, because that may make its way downstream at a later date.
Right. Understood. And you do telehealth, which is great. So are you in all the states in the US? Can anybody work with you?
So between me and my partner, we cover about 30 to 40 states via telemedicine. And then for people who are located outside of those states, we can still see them by telemedicine, and we would have them establish care with us with a visit. So a lot of people will they'll see us via telemedicine, establish care, and then they'll fly into Kansas City so that they're seen in person. And then we are telemedicine compliant and legal.
Ah, that's great to know. And I also noticed you have a podcast, correct? That you as well do?
Yeah. I co-host the Gillette Health podcast alongside Dr. Kyle Gillette. And we dive into interesting studies like this, talk about heart disease, hormone replacement for both men and women, and a lot of topics that we think are, high yield for our audience.
Beautiful. Yeah, so much great information. Definitely check out his podcast. And I will post links to all your contacts below and social media. And thank you so much for joining us today and sharing this really important information around disease prevention and peptides. And thank you as well for all the important work you're doing and helping your clients live a longer, healthier life.
Yeah, thank you so much for the kind words, and thanks for having me. This has been a lot of fun.
Remember, knowledge is power. The more you understand about your body, the better you're able to stay healthy and prevent disease. And a reminder, I'm not your doctor. Please don't take this as medical advice. If you have specific questions about your healthcare, feel free to reach out to your practitioner. And if you like this video, please like and share it with others. This information could really help someone you may know. And if you haven't already, hit that subscribe button below to be sure you don't miss out on our future shows. And I will see you all next Wednesday on the next episode of Discovering True Health.